Thank you for having me. I am Dr. Shouman from Mayo Clinic, Rochester, Minnesota, and I will be presenting to you a brief review of the management of autonomic failure in multiple system atrophy. To start, autonomic failure is a prominent and distinguishing feature of multiple system atrophy. It occurs early in the disease and may worsen as it progresses. It involves multiple functions that are under the control of the autonomic nervous system. Proper symptomatic management of autonomic failure can improve the quality of life in MSA patients. However, it is generally less than satisfactory. In this talk, we will briefly review the management of neurogenic orthostatic hypotension and, in the same time, supine hypertension, anhidrosis or lack of sweating, gastrointestinal dysfunction or GI dysfunction, such as constipation, bladder dysfunction, such as neurogenic bladder, including urinary incontinence and urinary retention, and erectile dysfunction. To start with orthostatic hypotension. Orthostatic hypotension means an orthostatic, or in the upright position, drop in blood pressure. It can lead to symptoms of orthostatic lightheadedness, brain fog, shortness of breath, exercise intolerance, especially in the upright position, tunnel vision, coat hanger distribution pain, which is pain around the back of the neck and the shoulders as the blood pressure drops upon standing, presyncope, which is the feeling of fainting, and syncope, which is loss of consciousness due to orthostatic hypotension. The basis of treatment of orthostatic hypotension is, in fact, conservative management of orthostatic hypotension. The medications that support blood pressure upon standing, which we will discuss later in our talk, would not be as effective unless the conservative management is optimized. And unfortunately, this is a frequently overlooked component of orthostatic hypotension management. Upon standing, postural counter maneuvers are helpful in preventing a precipitous drop in blood pressure. This has been reproduced in studies, and those maneuvers include crossing legs, squatting, and noodling legs. Activity modifications to support blood pressure upon standing and counteract orthostatic hypotension include avoidance of prolonged standing. If a certain activity requires a prolonged period of time, it would be preferable to sit down rather than stand, as prolonged standing would promote orthostatic hypotension and may lead to syncope. It is also useful to continue to move one's legs to promote venous return rather than standing still. If one is forced to stand, for example, in a line. Another type of activity modification would include squatting rather than bending over when reaching towards the ground. Bending over or bending forward and standing right back up may exaggerate the symptoms of orthostatic hypotension and the fall of blood pressure and lead to syncope. And graduated standing from a squatting position would ameliorate such response and make it less likely that one would pass out. Next, volume expansion is very important in the management of orthostatic hypotension. The idea is to have an adequate intravascular volume to support one's blood pressure and prevent major falls in blood pressure upon standing. This is primarily achieved with optimized fluid and salt intake. Usual guidelines are the following: daily intake of water or other fluids, but preferably water, of 80 to 100 ounces, or 1.5 to 2.5 liters. Similarly, increased dietary salt intake to about 10 to 20 grams of salt daily, the equivalent of 4 to 8 grams of sodium. This can be achieved by consuming foods that are high in sodium. Now, one should not overlook the other electrolyte that is important in this situation, which is potassium. Salt tablets can be utilized, and they are available over the counter, and also electrolyte drinks. We can measure the intake and how adequate one's intake is clinically by obtaining a 24-hour urine sodium study. And the usual number is about 170 millimoles of sodium per 24 hours and about 1,600 mLs of urine production. There is another form of water consumption that could be very useful in the management of orthostatic hypotension. And we usually recommend that patients take up to 1/3 to a half of their water intake, of their daily water intake, in this manner, which is water bolus therapy. And that is the consumption of 16 ounces or 2 full glasses, 8 ounces each, of plain water that is cold immediately before exercise or upright activity. This can be done up to 3 times a day. And the advantage is that it provides 16 ounces of water quickly. And the coldness of the water creates a reflex that promotes the support of blood pressure upon standing. Other means of supporting blood pressure upon standing are compression garments. These would compress the vasculature around the abdomen, the thighs, and the calves, and also promote the support of blood pressure when standing. Abdominal binders would compress the vasculature around the stomach, and so do compression shirts. Other means of compression include waist-high stockings or compression shorts. Patients with orthostatic hypotension should consider wearing these, at least in one form, at all times when standing. They can be taken off when the patient goes to bed. Exercise is very important in countering orthostatic hypotension. Exercise promotes the muscle growth which in turn promotes an increased intravascular volume and also tones the muscles, promoting the compressive function, helping with reducing venous pooling, for example. Exercise programs include cardio, and the goal is vigorous aerobic exercise 5 to 6 times per week with a minimum of 30 minutes per day. Modalities include recumbent biking, swimming, and rowing. What these three modalities have in common is that they are all in the recumbent or supine position, which is on purpose to avoid the effects of orthostatic hypotension on exercise. It's important to remember that patients with autonomic failure in multiple system atrophy have poor sweating function, which in the event of exercise can put them in or at risk of overheating, vasodilation, which would reduce blood pressure, and that in turn may preclude them from being able to exercise as well as they need to. For that, heat dissipation techniques, including spraying oneself with water, using a fan directed at oneself when exercising, and even wearing a wet t-shirt, for example, would be useful. Long cool down after exercise is also advisable. One should wait either in the pool after swimming or on the equipment after rowing or using a recumbent bike. One should wait until one cools down, pulse under 100, and then you get up. This is to avoid orthostatic hypotension after exercise due to vasodilation, overheating, etc. Another form of exercise program include weights, particularly lower extremity weight training. And this is to increase muscle tone, to promote venous return. And it is advisable to engage in such activities, 2 to 3 times per week, 2 sets of 12 repetitions. Those modalities include leg press, toe press, leg extension, and leg curl. Now, after we optimize the conservative management of orthostatic hypotension, we can then turn to the pharmacologic management of orthostatic hypotension. This is quite frequently needed in neurogenic orthostatic hypotension in the setting of multiple system atrophy, given the severity of this particular symptom. There are 4 medications that are most commonly used to help with the management of orthostatic hypotension, including midodrine. Midodrine is an FDA-approved medication to help with neurogenic orthostatic hypotension. The way it works is that it is an alpha agonist. This is a receptor present on blood vessels. And by agonizing this receptor, the medication causes vasoconstriction, that is the squeezing of those blood vessels, and that increases the blood pressure. It has a short duration of about 3 to 4 hours of activity. It is well tolerated. But since it affects the alpha receptors, it can worsen bladder hesitancy or emptying or urinary retention. It is rather inexpensive, and the dosing is generally between 5 to 10 milligrams per dose, 3 to 4 times a day. It is important to note that this medication can worsen supine hypertension. So when we say that the medication is to be used 3 to 4 times a day, this does not mean every 8 hours or every 6 hours. It means that the medication is to be taken before times of orthostatic stress, so before standing and during the day. And it should be avoided for at least 3 to 4 hours before bedtime. The other medication that is available and quite effective is Troxidopa. It is also FDA approved for neurogenic orthostatic hypotension. It promotes the increase of blood pressure and vasoconstriction. This is again the squeezing of the blood vessels by being a norepinephrine prodrug and being transformed to norepinephrine in the body. It is also short-acting, but somewhat longer than midodrine. It is more expensive, it is newer, and it is used in a dose between 100 to 600 milligrams twice or 3 times during the day. Again, this medication can worsen supine hypertension, and the way to use it is every 5 hours or so before times of orthostatic stress during the day, and should be avoided within 4 hours of going to bed in the supine position. One advantage that Troxidopa has over midodrine is that it does not usually tend to worsen bladder symptoms such as midodrine. Fludrocortisone is another medication that can help with orthostatic hypotension, not approved by the FDA, however. It is rather inexpensive and has been there for a long time. It has a long duration and can worsen supine hypertension because it works for a long period of time and is used once daily at a dose between 0.1 to 0.2 milligrams. The other medication that is not approved by the FDA and has a modest effect to counteract neurogenic orthostatic hypotension is called pyridostigmine. It's widely available, rather inexpensive. It does not affect supine hypertension or supine blood pressure. And the other advantage that it has is that it increases GI motility, which makes it desirable in patients with constipation. It is used at a dose between 30 to 60 milligrams 3 times a day. There are also delayed release preparations of the medication. Now that we have talked about neurogenic orthostatic hypotension, what other forms of blood pressure abnormalities caused by autonomic failure do MSA patients encounter? One form is postprandial hypotension. Post means after, prandial, after eating, after a meal. And it is hypotension, or reduction in blood pressure, occurring during or right after eating. It usually is more exaggerated after eating a moderate to larger meals, especially rich in fats and carbohydrates. The management then includes consuming smaller, more frequent meals, Drinking a large cup of water or another fluid with meals to support the intravascular volume. Some patients may consider wearing an abdominal binder as they eat to help support the visceral vasculature, that's the blood vessels around the stomach. And in certain cases, careful pre-medication, using a medication prior to eating, such as midodrine, can also be considered. Another form, and very important form of blood pressure abnormalities in multiple system atrophy is supine hypertension. Just like blood pressure drops upon standing because of failure of mechanisms of balancing blood pressure, the blood pressure precipitously rises in the supine position because of the disruption of these mechanisms in autonomic failure of multiple system atrophy. Symptoms of such increment of blood pressure are similar to symptoms of hypertension in general. They can be gauged by the patient by taking blood pressure in the supine position half an hour after going to bed or before getting out of bed in the morning, for example. But another indicator is frequent nocturnal urination, which is frequent need to visit the restroom to urinate at night. Why is supine hypertension problematic? Because it can lead to dehydration all overnight. If the blood pressure goes high, that blood is going to go to the kidneys, which in turn are going to produce more urine, hence the need to urinate frequently at night. And that is going to cause dehydration because the patient is not able to compensate for that loss of volume all overnight. And that will worsen the symptoms of orthostatic hypotension in the morning. And that is why a lot of patients say that their symptoms of orthostatic hypotension are actually worse during the first part of the day. The other problem with supine hypertension is the fact that high blood pressure going unchecked for a prolonged period of time, the hours of sleep, can lead to multiple complications known to be caused by hypertension, including cardiovascular disease, kidney disease, and others. So it is obvious that we need to address supine hypertension just as well as we address orthostatic hypotension. And the management can be quite simple, utilizing the fact that the blood pressure in autonomic failure drops upon standing. So to simulate a milder form of standing, we recommend the elevation of the head of the bed by 4 to 6 inches. Now, notice this is not done by pillows or by beds that bend in the middle. The whole bed should be up by 4 to 6 inches to avoid bending at the waist and promote a gentle fall of blood pressure at night. If this is insufficiently effective, some providers can consider a blood pressure lowering medication taken at bedtime, taking into consideration the fact that the patient has to wake up in the morning and has orthostatic hypotension because they need to stand up. So the agent that should be chosen should be short acting. So it would stop working in the morning and only work for the patient at night. So what are the pitfalls of orthostatic hypotension management? Well, first and foremost, inadequate conservative management. Many patients come complaining of difficult to treat orthostatic hypotension, but when you inquire about the amount of water, salt, the type of compression garments, exercise, they are suboptimally managed. Deconditioning is one other problem in people who cannot exercise because they do not know to exercise in their recumbent position, for example. Lack of understanding of medication mechanisms. This is especially true in the case of Myodegen and Northera, where people are given a 3-time-a-day prescription, and then that leads to the misunderstanding of taking the medication every 8 hours. And remember, supine hypertension is a problem already, and when you take your Myodegen right before you go to bed, first of all, you don't need it. Second of all, it's going to worsen supine hypertension. So the right way to use those short-acting blood pressure supporting medications, such as Myodegen and Northera, is to take it 3 times during the day, every 4 to 5 hours, and avoiding taking them 4 hours before going to bed. Similarly, fludrocortisone is not as needed. It's taken once daily, and it expands the volume of the blood. And the last pitfall is the undertreatment of supine hypertension, which we have discussed can lead to dehydration overnight and multiple complications of high blood pressure. Now, moving to the next symptom of autonomic failure in multiple system atrophy, which is anhidrosis, or lack of sweating. MSA patients can be affected by varying degrees of hypohidrosis, which is reduced sweating, and anhidrosis, which is lack of sweating. Anhidrosis can be the cause of exercise intolerance, as we have mentioned, because of overheating. Heat exhaustion, heat stroke are also serious complications of inability to sweat, because this is the main mechanism in which the human body is able to dissipate heat, and can worsen orthostatic hypotension, because when we are unable to sweat, the body reverts to the secondary mechanism of dissipation of heat, which is vasodilation, or making bigger the blood vessels in the skin. And that's why patients get flushed or red in the skin, and that is in turn going to reduce the blood pressure even further and would exaggerate the symptoms of orthostatic hypotension. So how do you manage anhidrosis? First of all, the patient has to understand that the main mechanism of dissipation of heat is not working very well, and that a proactive plan to dissipate heat should be in action. Number one, avoid excessive heat as much as possible. This is including being outside in hot summer days, and also being in poorly ventilated areas where people seem to struggle with heat. Having said that, this does not mean that one should not live their life. So if one is planning to be in a situation where there is an increased ambient heat, then one should plan. So pack a small fan. There are multiple fans that are available that could connect to one's phone or are battery operated that can move a lot of air. Also pack a spray bottle with water in it. There are also cooling garments available, including headbands and shirts, and also cooling vests. When in a situation where other people seem to be sweating, one should use those modalities. So spray yourself with water. Use the fan to dissipate, to move the air, to cool oneself off. Use those cooling garments, maybe ice packs. cooling vests. If the people around you are sweating, you should be sweating as well. And if your body cannot mount this sweat response, you should be doing it artificially by using those tools. Do not wait until you start overheating. You should be proactive about heat dissipation and heat management. If those modalities are ineffective, consider leaving. If you are in a warm place and these tools are not effective, they're not working, leave, go to a cooler, maybe air-conditioned place, lie down, and continue cooling yourself off. If symptoms of heat exhaustion or heat stroke should arise, then call for help. How about gastrointestinal dysfunction or GI dysfunction? This problem is frequent and often very bothersome in patients with autonomic failure of multiple system atrophy. They include early satiety, which is the feeling of satiety or fullness early on in the meal after just eating a few bites, and this is usually related to gastroparesis. Postprandial nausea or nausea, feeling of discomfort after eating. And very prominently, constipation or difficulty with bowel movements. The management of GI dysfunction and primarily the symptoms of gastroparesis and constipation include conservative management, including more frequent, smaller meals, exercise, which promotes the motility or the movement of the gastrointestinal system, hydration, which helps with the consistency of the bowel movements and promotes the GI function. A good bowel regimen, increased fiber in diet. There are certain laxatives that are bulk forming, such as psyllium or psyllium. Certain stool softeners, they don't help with the movement of the GI system, but rather make the stool softer and easier to pass, such as Docusate. There are other multiple forms of laxatives, including non-absorbable sugars, such as polyethylene glycol or Miralax. Newer agents include fatty acids, such as Linzess. There are also certain stimulants of the GI tract. One that we have mentioned briefly in the management of orthostatic hypotension is pyridostigmine, which makes a certain neurotransmitter called acetylcholine more available and can promote the GI system function. Now, coming to bladder and erectile dysfunction. Bladder symptoms are common in multiple system atrophy and are related to different stages of development of a neurogenic bladder. Urinary frequency and urgency are frequent symptoms of neurogenic bladder in multiple system atrophy. There are multiple medications and medication classes that may be useful in this condition, and those would include a class of medications called anticholinergics. These block the function of acetylcholine at the level of the bladder, and they include agents such as oxybutynin, tolterodone, or teltoridine, and Troxidopa. Another class of medications that help with urinary frequency and urgency are beta-3 agonists, such as mirabegron. The caveat with these is that they may worsen urinary retention, because in the condition of neurogenic bladder, one could have both urinary frequency and urgency. And also the other caveat for anticholinergics is that they block the effects of acetylcholine, and that can worsen anhidrosis, or lack of sweating as well, which may be problematic. Urinary hesitancy and retention can be managed using a class of medications called alpha blockers. Those include tamsulosin and alpha-zeusin. Now, remember when we talked about the management of orthostatic hypotension, we said that one class of medications is alpha agonists, so medications that promote the alpha receptors. Midodrine. So the caveat in having to use alpha blockers to help with urinary hesitancy would be worsening of orthostatic hypotension. Another way to help with urinary retention and hesitancy is intermittent catheterization. In more severe forms, urologists can consider other forms of management, including surgical management, such as a suprapubic catheter, which is a catheter that is inserted at the level of the lower abdomen, just above the pubis. And also there are certain procedures, including Botox treatment, that may help with the function of the external sphincter at the level of the bladder. For urinary incontinence, pads and diapers can also be utilized, and sometimes permanent catheters, either Foley or a suprapubic catheter, as we have mentioned, can be utilized. How about erectile dysfunction? Erectile dysfunction is also common when talking about autonomic failure in multiple system atrophy. It can be an early manifestation, and it can be difficult to treat. Usually PDE5 inhibitors such as sildenafil and tadalafil are used. The caveat is that they worsen orthostatic hypotension, so the patient should be careful about activities in the upright position after taking those medications. Other forms of treatment include topical injections and mechanical devices. Finally, I would like to conclude with some take-home points. Multiple system atrophy is characterized by progressive motor and, very importantly, autonomic nervous system involvement. Symptomatic treatment of autonomic failure in multiple system atrophy can help manage the various problems and deficits associated with multiple system atrophy, but is generally less than optimal and associated with many pitfalls. Please do not overlook conservative management for neurogenic orthostatic hypotension, supine hypertension, constipation. It's very important. A multidisciplinary approach to management is needed. As we mentioned, the management of autonomic failure in multiple system atrophy includes the management of failures of multiple systems, the GI system, the bladder function, the sexual function. And it's not uncommon that we need to reach for the help of specialists in these fields. And hence, the multidisciplinary approach is very important and useful. Finally, I would like to thank you for inviting me to do this talk, and thank you for listening. And I would be more than happy to take any questions that you may have. Thank you.
Hi, everyone. Thank you for joining us for this session. I'm Diane Adkins. I'm a member of the Coalition's Board of Directors, and I'm going to be moderating your questions for our speaker. So please continue to enter your questions in the Q&A box at the bottom of your Zoom screen. Dr. Shouman, thank you so much. Here's our first question. I am a late stage MSAC patient. Is it common to have paralysis of vocal cord on exhalation confirmed by endoscopy, paralysis of diaphragm confirmed under fluoroscopy in dysautonomia?
Hi, can you hear me?
Yes.
I would say that respiratory symptoms are very important to watch for in multiple system atrophy. The one respiratory symptom that we always ask patients to keep an eye on is stridor. We see that up to 42% of patients with multiple system atrophy. And that actually can result from various abnormalities to the vocal cords and the region over there, including paralysis. I would say this is more of a motor symptom of multiple system atrophy rather than an autonomic symptom. And it results from various reasons. But one of the important causes is the degeneration of the controlling nuclei or the nerve cells within the brainstem. The diaphragm paralysis is probably less frequently encountered, but I would say that it is also the result of the same process, because the centers that control the diaphragm also lie in the brainstem, and those are well known to be involved in multiple system atrophy.
Okay, thank you. The next question is, how could we solve the disorder of erectile dysfunction without any medication? Because the medicine, as you said, may cause OH. Is there any safe medicine?
Well, that's, as I mentioned in the talk, it is a rather difficult symptom to treat. There are certain procedures and devices that the urologist may use, and those would have more of a localized effect to the region rather than a systemic effect that may drop blood pressure.
Okay. Next question is, what can I do to reduce the sick feeling I have with my PAF?
So PAF is the cousin of multiple system atrophy that doesn't have the motor symptoms. The nausea can be the result of autonomic dysfunction because of the features of early satiety and constipation. It can be pretty difficult to treat. Sometimes we use antiemetics to help with that. The other conservative management for gastroparesis that we recommend for people like small frequent meals may sometimes be helpful, but it frequently can be pretty difficult to treat.
Okay. Can you define for people that might not know what an antiemetic is and a particular one perhaps?
Yeah, so medications that help with nausea, so nausea medications. that people use, Zofran, etc.
Okay, great. The next question we have is, I have recently developed stridor when sitting quietly. Is there anything I can do to lessen it? It scares people to death, LOL.
I know, and I always ask people about this symptom, and I ask spouses and families whether or not they hear it at night. And it can actually sound pretty scary. I would say that it is mostly scary at night because it can be very serious. It can cause a breathing disruption. So for the nighttime, we usually refer patients to pulmonary medicine. They usually do sleep studies or sleep medicine as well. And like I mentioned, things like CPAP or BiPAP can help. Obviously, in advanced stages, people may need a tracheostomy, which is a breathing tube around the neck. I would say that during the day, it may be scary, but it will probably be less likely to pose a major danger to life. But I'm not aware of any medications that would make that sound less scary.
Okay. It's good to know that it's not as much of a problem in the daytime. And we have an anonymous attendee that asks, comment on the use of atomoxetine, in NOH.
So atomoxetine can be useful. It is probably going to be effective to a point. It makes norepinephrine somewhat more available. Some patients may find it beneficial. We usually use it in adjunction to other medications, not as the only medication.
All right, Lorraine asks, my husband's OH seems to get worse as the disease progresses, and he's on 3 different medications for OH. Is this common?
So autonomic symptoms, primarily orthostatic hypotension, can definitely worsen as the condition progresses. Like I said, sometimes we re-emphasize conservative management to identify some lapses in that, and that could be helpful to support the medications. But unfortunately, in certain cases, it can be quite difficult.
This person says, this is from Trevor, I was fortunate enough to be treated by Dr. Shouman at Mayo. I follow all the advice that Dr. Shouman has presented and has been very effective in controlling my MSA symptoms. Just wanted to say thank you. So that's a nice positive comment for you this morning, Dr. Shouman.
It's very kind of you. Thank you.
Yes. Another question, this one from Gary. Why do I feel so much better in the late evening and upon getting up in the morning feeling so bad again?
So certain patients do feel better towards the later stages of the day or the evening because their blood pressure tends to go a little bit higher. So if that's related to blood pressure, then in the morning, especially if supine hypertension is a problem, things like dehydration can happen and affect or worsen orthostatic hypotension in the morning hours. That could be a possible reason.
Yeah, that sounds familiar to me in our experience. I am suffering from MSAC since 3 years of diagnosis, suffering from slurred speech with other symptoms like constipation, movement disorder, etc. The doctor said that I don't have OH yet. I'm feeling dizziness after standing. Is that OH?
I think that is quite possible. I would suggest that patients with multiple system atrophy who experience orthostatic symptoms share those with their doctor because of the fact that dizziness can come in multiple forms. We usually experience orthostatic lightheadedness, feelings of pre-syncope, and sometimes even loss of consciousness when people drop their blood pressure. So it is important for the physicians to perform orthostatic vital signs or tilt table studies to try and investigate dizziness in patients with multiple system atrophy to see whether or not this is reproducible in testing and whether it is related to changes in blood pressure or not. Because a patient with multiple system atrophy may have another process that can cause other type of dizziness, including things like vertigo. So I would say that it is important to the patient to discuss that with their physician.
This is sort of adjacent to that question. Fortunately, I have not developed OH. Should I expect symptoms at some point? This is actually something that was true for my husband and me, that he did not have it for a long time. So I'll let you answer it.
Yeah, no, I agree with you, Diane. It is a multiple system disease and does affect the autonomic nervous system in multiple aspects. One of them is orthostatic hypotension. Obviously, we spend a lot of time talking about that because it is a major source of disability, but not everyone has to have it, and not everyone has to have it early on in the condition. It can affect mobility, and because one would need to be, stand up and walk and engage in activities. So I would say that if the patient becomes symptomatic in terms of orthostatic lightheadedness, more orthostatic, tiredness, fatigue when walking, that's probably the time to check for orthostatic vital signs and inform their physician, because the management of that may improve quality of life there.
It's another question. I have MSAC and am in my late 70s. I have frequent problems in shortness of breath, even without exercising. I just had a cardiopulmonary exercise test. It took almost 24 hours for shortness of breath to calm down. Is this an MSA issue or not?
So this could be related to two, well, obviously, if there's a cardiopulmonary problem, that would be, separate, that requires attention there. Just to be more general, I'm not giving a specific diagnosis here, but in general, going back to the previous question, with orthostatic hypotension that can happen with MSA, that can cause shortness of breath in addition to other symptoms of exercise and intolerance. So that could be a possibility. And we also, going back to the first question with the motor symptoms of multiple system atrophy affecting the breathing on multiple aspects, including the vocal cords, and also weakness of the respiratory muscles, those can happen. So those can add to symptoms of shortness of breath and multiple system atrophy.
Okay. Alan asks, well, he says the abdominal binder does not help me, needs practical advice on putting it on, what type, etc.
Yeah, I usually ask people to see how, the tightest they can fit around their abdomen. Frequently, I'd recommend for patients to consider biker shorts instead. So see if that helps, because of the fact that this covers a larger area. The splanchnic vasculature, that's the vessels around the abdomen, do have the ability to house a lot of blood. So the compression thereof can be helpful, but also the thighs. So the thighs, they can house a lot of blood as well. And I would say that things like biker shorts can cover both areas. Tightest you can fit.
That's really helpful. Belinda asks, I have both urinary urgency and urinary retention. I did not want an indwelling device, so tried self-catheter, but tremors and stiffness prohibited that. I found during a hospitalization the pure wick external catheter urine collection system. The pump solved both retention and incontinence. I now use it at home and have not had a UTI in years, nor skin breakdown from pull-ups or diapers. Is this now recommended and used more for patients that cannot feel their bladder expanding, which they found during an urodynamics test?
I do see it more frequently used. Like I said, we usually share the care of our patients with our colleagues in urology. They usually know a little bit more about those devices than we do, but have certainly seen this being used a little bit more in practice.
Okay, that was a new one to me. I've not heard of that device before. This Bill asked, my mom does not have OH yet, but after listening to you speak, I do think her blood pressure drops after she eats. What is that called again, and how is it best diagnosed? Should we get our own blood pressure cuff?
So there is a condition called postprandial hypotension. This symptom can be a part of autonomic dysfunction, but it's a variety of autonomic dysfunction that can cause this, and it does not mean that a person has multiple system atrophy or one of those conditions that we're talking about today. I would say that in clinical practice, one of the tools that is useful is obviously a blood pressure cuff, taking your blood pressure before and after a meal. Sometimes when we see patients who complain of episodic drops in blood pressure, including postprandial hypotension, we utilize longer term monitoring, like a 24-hour blood pressure, and we see how the blood pressure and heart rate respond around the times that the patient eats. So that could be a useful tool.
Okay. Linda asks, would breathing exercises improve respiratory issues? If so, which do you recommend?
I would recommend working with a respiratory therapy team, because of the fact that every person could be different, and certain exercises may not be suitable for every patient.
Right. Good. Julio asks, how do you know what stage in the disease a person is in?
You can only know that by following the patient over time. It would depend on the onset of symptoms, the systems that are involved in the severity of motor and autonomic dysfunction.
Anthony asks, I was diagnosed with MSAP in June 2020. Only 1 year later, I am a changed person. The illness has progressed quickly. Can I expect that it will continue to progress quickly?
In general, progression in MSA does vary. Certain patients can progress quicker than others. Like I said, the best way to know that is close monitoring with one's physicians.
Okay. We've got time for one more question, and so I'm going to ask this one, which is also Julio. Do we or can we see a medicine that slows the progression of this disease soon?
I really hope so. There's a lot of research going on. The reality is that this has been a difficult task to achieve. But I know for a fact that there are multiple centers engaged in research for this specific topic, including the Mayo Clinic.
That's great. Good to know. And someone else I missed earlier, but has mentioned again, just for us to please suggest voice therapy for the speech problems that go along with this disease. And I know that we'll cover this in other sessions as well, but I would agree that that's a really important intervention. It was for us. And so,
very important.
Yeah. So So we're at the end. Thank you so much to Dr. Shouman for an excellent presentation. I think you covered a remarkable amount of information in a short period of time. So have a great conference, everyone. Hope to see you in other sessions. Thank you so much.
Thank you, everyone.